Very happy to have you here. We've already had a wonderful first session, and now we continue on talking about early mobilization. My name is Shawniqua Williams-Roberson. I'm Assistant Professor of Neurology and Biomedical Engineering at Vanderbilt University Medical Center.
Hi, I'm Fernando Zampieri. I'm a critical care physician and an assistant professor at the University of Alberta in Edmonton, Canada. Thank you so much for being here today.
So we will start off our presentations with Dr. Bhakti Patel, who is an assistant professor at University of Chicago, and she will discuss with us what is early.
All right, these are my disclosures. So when we think about clinical trials for ICU rehabilitation, it becomes quite clear that although they have similar interventions that we're thinking about sort of preventing disability in patients, we describe it in many different ways. So these are the titles of landmark clinical trials that we think of when we think about the evidence base for early mobilization. They describe the intervention as mobility or physical and occupational therapy, or describe it as goal-directed, perhaps standardized, intensive, and even active or structured. And while we're all thinking that these are similar trials looking at rehabilitation, the interventions are not quite standardized in terms of what their definitions are. You would think that for an intervention that is based on timing, that timing would also be measured in a standardized way. However, when we look at these clinical trials, they all list a different time that's a starting point. So some measure time from ICU admission, which seems clinically relevant for patients who never were intubated. Others, which are the majority that enrolled patients who are on mechanical ventilation, it would make sense or have clinical relevance to anchor that timing to ICU or to intubation. However, many trials set their timing based on the time of randomization or enrollment, which has some validity within the context of a trial, but is hard to understand or translate to clinical care at the bedside. And others, despite being included in the evidence base for mobilization, don't provide any clarity about timing at all. Some say days to this event, however, days from what is unclear. It's more important then to say, fine, we have a starting point that either could be clinically relevant or related to a study, but what is the ending point? Like, what is intervention? Is it evaluation by a physiotherapist, whether or not intervention was being delivered? Is it passive range of motion, which is the sort of standard treatment given to the usual care group and also was shown to not have any clinical benefit? Is it physical therapy, which has just as vague of a definition across protocols? Some describe it as initiating in-bed mobility. Others do transfer training, may progress to balance training, resistive exercises, or even include or not include occupational therapy. Or should the event be to a mobility milestone, something that you and I can see and say, this person achieved this level of activity during their session today? And there are validated scales for this. One is an ICU mobility scale, the IMS scale. It has a lot of construct validity. It's reliable in terms of a measure of determining how much activity was achieved during a session. And it's a scale that goes from 0 to 10, where 0 means no activity and 10 means walking independently. And what I would say is sort of the inflection point of a minimum dose of therapy would be one that moves from a passive motion to active motion, upright positioning that would lead to out-of-bed activity. And that would be sitting at the edge of the bed and dangling the legs. Anecdotally, from our clinical trials, we found that patients awaken the mind when they have that positional change. They tend to start doing thought about clues, about righting themselves and adjusting their balance. And that perhaps might be the minimum dose to say that this is the first time you're actively sort of out of bed position. In addition, clinical trials that have shown some benefit with early mobilization have had short timing to this mobility milestone and have achieved that in over 80% of the patients. So perhaps this is the minimum dose for therapy. So if we want to standardize the timing of mobilization, just so that we're on the same page, perhaps that we should start it based on the timing of intubation, because we're focusing on patients who are on invasive mechanical ventilation, and then measuring it to a mobility milestone, which I would say would be the first event of active therapy, would be sitting at the edge of the bed. And so what would be the appropriate time frame to achieve for mobility? So you can define the timing based on what we're trying to prevent. Ideally, we're trying to prevent physical disability or muscle loss or weakness, and so perhaps we can gain clues based on the pace of muscle loss that we see in ICU patients. You could also define the timing based on what are we trying to prevent in terms of cognitive impairment. We know that the duration of delirium seems to increase the chances of long-term cognitive impairment. Perhaps we should time our therapy to prevent that from that duration being too long. And then finally, we can learn from our prior experience. What is the timing across clinical trials? And perhaps can we learn when we look at trials that found some benefit versus trials that did not? So this is a systematic meta-analysis looking at the pace of muscle loss in healthy adults and the effect of bed rest. So in the first line, you'll see there's atrophy, and then the second line is strength. And what you'll find is that atrophy vastly underestimates the degree of weakness that is seen clinically. However, if you take a healthy adult and confine them to bed rest for 4 months, at most they'll lose about 20% of their muscle mass, which means about a fraction of a percent a day. Now, if you contrast that to a recent meta-analysis done in ICU patients looking at muscle bulk, measured many different ways, either by thickness or surface area in the upper or lower extremity, there's a dramatic acute loss of muscle mass that comes out to about 2% per day. To put that into context, it takes 10 days to lose that 20% that a healthy adult would lose in 4 months. In addition, if I wanted to detect clinically apparent weakness that I can detect as a non-neurologist, at the bedside, that weakness is typically seen at around 10% muscle loss. So patients would have this clinically apparent weakness as early as 5 days into their ICU stay. So ideally, some intervention would happen before that weakness has set in. When you think about the relationship between duration of delirium and cognitive impairment, in a large sample of 800 patients with respiratory failure and shock who were followed over a course of a year to do in-depth neurocognitive testing, this was published in the New England Journal in 2013, what they found was this, that patients had a longer duration of delirium were more likely to have cognitive impairment. And what you see in that first half of the graph, that in the first 5 days, there's this dramatic sort of stepwise decline in lower cognitive scores and then sort of plateaus after 5 days. So perhaps interventions that reduce delirium below 5 days perhaps might have this long-term cognitive benefit for patients. And let's think about the timing across clinical trials. And I will say with a caveat that not all trials define time zero the same, so this is our best guess as far as I can tell from the methodology. And we look at specifically the timing that from intubation to physical therapy or sitting, if sitting was reported in their manuscripts. So if you look at the Moss study, patients were on average receiving intensive physical therapy 8 days after intubation. For the Morris study, it allowed up to 80 hours of mechanical ventilation, so a little over 3 days prior to enrollment, and then patients experienced their first physical therapy session 3 days later, so a total of 6 days to intervention. In the Wright study, patients on average had 4 days of mechanical ventilation before enrollment and then received physical therapy 4 days after that, so again, 8 days to intervention. In the team study, there was about 60 hours to enrollment, so 2.5 days, and then 3 days to sitting at the edge of the bed, so 5.5 days to intervention. In contrast, in a group for the surgical ICU patients were allowed up to 48 hours of mechanical ventilation and achieved sitting at the bed on day 1 of study, so 3 days. In the Schweikert study, it was 1.5 days from intubation to sitting, and then in our recent study, it was a little over a day after intubation. And what you'll see is that from the team study downwards, that there was a higher time to intervention in these trials that did not show clinical benefit. And then for trials that had a more acute or hyperacute time to intervention, there seemed to be some effect. And so when we're trying to think about the window of opportunity to mobilize, ideally it would be shorter than the negative trials, perhaps even shorter than the control arm of our recent trial in order to see perhaps some benefit in terms of preventing disability from the physical sense as well as cognitive impairment. So achieving out-of-bed activity within at least 4 days, ideally 3, if patients on mechanical ventilation, and primarily this time frame would allow you to get ahead of the 10% muscle loss and the clinically apparent weakness, perhaps reduce the duration of delirium, as these other studies had shown that you can reduce it by half if you do it in that acute period, and that perhaps this is earlier than previously reported in other clinical trials. So how can we achieve that early timing? I can tell you that we should just walk to the moon, and like that's not achievable. So how are we going to do that? And so what I would say is that by far and away across these trials, sedation was the major barrier. And yet we think that it's immovable, although it's something that we choose. It's a supportive care practice that is not necessarily therapeutic. And for all the things that I've heard that sedation achieves, you would think that there would be no hypoxemia in the world, there would be no dysynchrony, there'd be no patient self-inflicted lung injury, and yet all of those situations still exist for the amount of sedation that we give. But if you go back to the seminal literature looking at the criteria to awaken patients in terms of the ABC trial, awakening and breathing coordination, when you look at what was the criteria to say patients were ineligible for awakening, those criteria are quite narrow. It's either that you had sedative infusion for active seizures or for alcohol withdrawal, that you had escalating sedative due to ongoing agitation, that you had neuromuscular blockade for which the indications have become quite narrow. If you had active acute myocardial ischemia or increased intracranial pressure. These conditions are not widespread or common, and yet we're not awakening patients in that early period. So we're not applying the high-level evidence that shows that that coordination of awakening and breathing is not happening. In addition, that coordination of the sedation has to happen with therapy, so it does require a cohesive team to coordinate that timing, along with all the other tests that are happening in the acute period of ICU stay. And then finally, some of these trials have criteria for initiating therapy that could be either very conservative or very aggressive. So if you pick a very conservative strategy where the criteria mirror what it would be to liberate someone from a ventilator, you're destined to have late timing of therapy. In addition, if you have criteria that prevents patients from doing upright positioning, such as they need to raise their arms up or follow commands, then you're essentially sentencing the person to stay in bed, and then you say, you're too weak to stand up or to sit up, but then we'll wait another day where you'll be weaker to sit up. And so it's important to think about what are the criteria to progress therapy. With that, I just want to acknowledge our multidisciplinary team that accomplished many of these trials, as well as acknowledge the three men in those photos. They're graduates of our clinical trial, all mobilized with ARDS. The last one actually was on ECMO and were able to return to their lives without disability afterwards. So thank you.
We have just a few moments for questions. Any questions for Dr. Patel? I was actually curious, if you don't mind. So can you tell us a little bit more, being from a place where we study a lot of delirium, the idea of simply having that upward positioning seems like that would I guess, impact the cognitive health a lot. Is that what you see sort of clinically, and what do you think about that?
Yeah, what was interesting is that sometimes people stand outside the room and then look at someone and say, they're not going to do much today. And the number of times I was surprised that even when you awaken, and they might not follow commands like in bed, but you sit them up, it's like just that position change and that proprioception. And I see you nodding your head. They open their eyes, and then even if it feels like it's full assistance to sit them up, when you kind of let go, they right themselves because they sense that you're not holding them up. They start shifting themselves in bed, start trying to find a comfortable position. I feel like that creates this awakening of the mind and body connection where finally the patient is interacting with their environment because you have forced a position change on them. It also is, as someone who is an advocate for doing parallel physical and occupational therapy, it's the right position to start simulating activities of daily living so that you can combine mobility with activity in terms of what you would do in your everyday life. So it is surprising how much more they can do just by getting them upright in bed.
So, and kind of imagining the possibilities as opposed to sort of assuming that they're going to first show it to you seems very important as well.
Yeah, and another thing was that it's really silly, but bringing socks into the room because it's the intention to make them stand. No one wants to have bare feet on the floor, and so if you have to go back to the supply room to get the socks, your patient will not stand. So it's just the intention to say, I cannot predict how much you will achieve, but I do not want to limit you based on what I'm prepared for.
Thank you very much for
Yeah.
those insights.
Thanks.
Thank you so much. So I have the pleasure to invite Professor Leo Heunks from the Netherlands for the next talk. Thank you so much.
Thank you very much. Thank you very much for the invitation. It's a real pleasure and honor to discuss early mobilization right here. So these are my disclosures. I don't think there's anything related to this presentation, but I have a disclosure. I love to exercise. Just 1 hour of running outside makes you feel better. So I would like to believe in early mobilization for our patients, right? And indeed, professional organizations recommend exercise, or Society of Critical Care Medicine recommends early mobilization as part of the care for our patients. There's a strong physiological rationale for early mobilization. Our ICU patients are mostly bed-bound, so they're not using their peripheral and respiratory muscles. So there's disuse atrophy, resulting in weakness, and we know this is associated with adverse outcome. So, early mobilization, we're limiting disuse atrophy, and we hope to improve clinical outcome, right? So why are we discussing this topic? I mean, it seems to be clear from a physiological rationale, right? Well, I think there have been some great papers published in the last 2 years that put this topic into a little bit of nuance. And I would like to discuss these 3 papers briefly. So first, the TEAM study, which is an international randomized controlled trial of early mobilization versus standard of care, and the primary outcome was numbers of days alive and out of the hospital after 6 months. So just a bit on the patient characteristics. The typical ICU patient, 60 years of age, a little bit obese, BMI of around 30, time from ICU admission to randomization, as said by Bhakti, around 60 hours, PF ratio 230. So what was the intervention? These were sessions individually tailored to achieve the highest possible level of mobilization that was deemed safe. Main results, primary outcome, a little bit disappointing. No significant difference in number of days alive and out of the hospital at 6 months, as you can see right here. 6-month mortality, no significant difference. If anything, it's higher in the active mobilization group. But then I always like to go to the online supplement. What did they actually do with the patients? So look right here. So this is, So this is the day of mobilization, day 1 to 28, and the minutes of mobilization per day. Right here in black for the standard of care patients, around 8 minutes, and this for the active mobilization patients, 19 minutes. So if you think about it, does a difference in 11 minutes of day of exercise make a difference in 6 months mortality? 6 months, after 6 months, ventilator-free days. If you look at it from a physiological perspective, but happy to discuss, it's hard for me to imagine this, right? So this is an important point for discussion. Adverse events, nicely discussed earlier this morning in the opening session, significantly higher. I'm sorry, I could not incorporate your trial just published an hour ago, but this is what we have so far from the TEAM study, significantly more adverse events in the early mobilization group. And this was mainly cardiac arrhythmias and oxygen desaturation. So my interpretation here is that the difference in mean of 12 minutes of physiotherapy a day does not make a difference in clinical outcome. Important to say that many patients in the active group did not receive the intervention because of sedation, hemodynamic instability, and other reasons. And there were more adverse events in the early mobilization group, but I think we have to be careful here. I don't think this trial shows that or at least we cannot conclude from this study that early mobilization does not work. It does not work for these patients in the way the study was designed. The second study I would like to touch upon is this one, published in the Blue Journal, the STAND trial, which is a step-wedged cluster randomized trial evaluating the effect of implementing a multifaceted approach to increase mobilization among ICU patients. So this is not mobilization against standard of care. The primary outcome was the peak documented intensive care mobility scale within 48 hours of ICU discharge. I don't have to go over it. Bhakti explained it very nicely. But just remember, an IMS of 3 means you can sit over the edge of the bed. So what was the intervention? It is basically a kind of closed-loop communication. So early in the morning, nurses and physiotherapists, the whole team, would decide upon the mobilization goals of this specific patient for today. So is this patient going to sit upright in bed, in a chair, stand, walk? So they just defined mobilization goals. They were reported in the medical record or just in the patient room. And then at the end of the day, this was reviewed. Did we reach the mobilization goals? If not, what were the barriers, sedation or whatsoever? So that's important. That's the setup of this trial. But unfortunately, no significant difference in the primary endpoint. IMS, 3 in both groups, within 48 hours of ICU discharge. Again, disappointing. So the STAND trial is a pragmatic trial for increasing mobility goal settings, and it shows that it does not improve mobility at ICU discharge. It must be said that the levels of physiotherapy were rather low in both groups, and I think it is very important to realize that implementation of an early mobilization program seems to be quite difficult. And finally, this paper, the first author is right here. I think it's a fantastic paper. It's a single-center parallel randomized controlled trial in invasively ventilated patients with the intervention early mobilization versus usual care. And the primary outcome, very interesting, is the cognitive impairment at 1 year, rated in the Montreal Cognitive Assessment Score. So this is a 30-point score that assessing multiple domains of cognitive function. So the patient has to draw this cube, name the animals, different tests for memory, attention, and so on. So the max is 30, and cognitive impairment was defined if you have less than 26 points. The intervention, it's physical and occupational therapy after the interruption of sedation until hospital discharge. So not only in the ICU, until hospital discharge for 25 to 30 minutes a day. So the time to the first session of physiotherapy, much shorter in the intervention group, median of 1 day versus in the usual care group, 4.7 days. So that's an important difference. Also, the number of sessions, of physiotherapy sessions, significantly higher in the intervention group. So something happened, right? And this is really interesting. So the cognitive impairment after 1 year after ICU discharge. Cognitive impairment was significantly more frequent in the control group as compared to the intervention group. However, there was no significant difference in functional dependence or mental quality of life at 1 year. So I think it would be nice to discuss what is the clinical relevance of this finding. But it is an important finding. Also very important, I think it's a very important relation here with delirium. First, the incidence of delirium is quite low in their ICU, but still, in the intervention group, the duration of ICU delirium and the proportion of days that patients were in delirium was significantly lower in the intervention group. So how do we interpret this study? I think it shows that early mobilization improves cognitive, and in this trial as well, physical outcome, but it does not have an effect on quality of life or functional independence. And it's interesting to discuss how early mobilization affects the cognitive function. Is this related to sedation? Is it just the occupation, not just, is it the occupational therapy doing certain tasks? I think it's an important question, but I don't have the answer yet, and it is important. And the limitation is that it is a single center study. This in one slide, this is a very nice meta-analysis published in New England Journal of Medicine, first author here as well. So I'm going to be very short. A systematic review meta-analysis that addresses this question. In ICU patients, does early active mobilization as compared with usual care improve outcome after 6 months? Well, they included a lot of studies. You have to read the paper for the full details. I don't have the time for that right now. But there was no significant difference in clinical relevant outcomes, days alive at 6 months. So I think this systematic review showed that they were unable to identify long-term benefits of early mobilization. There was a higher risk of adverse events and possibly even a higher mortality, but maybe we have to tone down this conclusion right now. But the question is there still an effect in subpopulations? Maybe we need to go back to this slide where I just started. Life seemed to be so simple. I mean, inactivity, disuse, weakness, poor outcome. But maybe this is too simplistic. It is not just disuse atrophy in our patients. We recently described this for the respiratory muscles, but I'm quite sure it is the same for peripheral muscles. If you look at the pathophysiology of muscle weakness, of course there will be contribution of disuse atrophy. But there's a lot of other factors at play. Maybe lengthening contractions, or lengthening activations, I should say. Maybe load-induced injury, a muscle that is highly inflamed. Maybe strenuous exercise exacerbates injury. It's the exposure to systemic inflammation, to drugs, that may have an effect on muscle function. So I think it's way too simplistic to think that disuse atrophy is the main component of weakness and we can just reverse it by early mobilization. You know, and I like this, but I'm a little bit biased. I like this video. So this is in our ICU. We have this dedicated swimming pool for ICU patients, for ventilated patients. You know, we can do a randomized controlled trial. We can do every trial. I think we will be unable to show the benefit of this early mobilization intervention for our patients. But if you ask the patients, they really like it. They like this way of mobilization. It motivates them to do the rehab. It really makes a difference. But an endpoint, if it changes physical performance after 6 months, I'm not so sure. So to conclude, early mobilization. I think, yes, there is a physiological rationale, but things are much more complicated, and we have to be careful for the adverse events. So it's about selection of patients. It's about the timing of patients. That is important. Maybe the early mobilization, and I think that's what we're working on, is just part of a toolbox of interventions. It should include cognitive training, occupational therapy. You can think, I mean, a lot of ICUs are working on gaming, on music, on just being out there. I think it should be part of a toolbox. It's not just rehabilitation. And I think an important thing here, and that is what I have learned from the trials. I mean, like 5 years ago, I would say whatever happens, this patient needs to be mobilized. Honestly speaking, I'm a little bit careful now, just as a doctor. If the patient doesn't want to be mobilized, I'm not sure that I have the evidence. I don't care what you want. You have to be mobilized. So in that, my opinion changed a little bit. Thank you so much for your attention.
Thank you so much. That was great. Any comments from the audience? Yeah, sure.
I will speak up. I think what is important, mobilization and exercise is a catabolic event. So normally in anabolic situations...
Just one moment. Can you grab the microphone?
Exercise is a catabolic event. So normally after a catabolic event, so when you run the marathon, afterwards you will eat and you have an anabolic situation, you will build up your muscles. In ICU patients, probably we don't have this anabolic signaling. So, as you said already, maybe we can make things worse in some patients. So there's maybe subgroups of patients that can benefit from the intervention, that can have this anabolic signaling and effect, and some patients maybe can be harmed by, well, overtraining their inflamed muscles. So, what's your opinion about this idea?
Thank you for the question. I think it's a very important comment, and it's going to be really exciting if we can find muscle biomarkers that help us to identify the patients that may benefit from mobilization, or other patients that you would say, well, maybe we need to delay or find other ways of mobilizing the patient. So I completely agree with you, Matthieu.
Okay, we have to move on. Thank you so much.
Thank you.
Thank you for the presentation.
So next we will have Michelle Paton, who's an advanced critical care physiotherapist from Monash University in Melbourne.
Thank you for the introduction. So I'm going to probably, hopefully, divulge some of those subgroups and give some information on subgroups. So I'm going to give a talk on exercise dosage. So the plan for today, I'll break down what dose is. We know that it is comprised of multiple components. I'll provide a bit of summary of some of the current evidence, not just some key publications, but some results of our systematic review that we're just finalising now, which does have 90 studies in it and just over 8,000 participants. So this will be the largest collection of evidence, and that search is up to date to October last year. And I'll outline some future directions and some key messages. So as an exercise physiologist, that was my first degree, we talk about the FIT principles when we talk about dosage. So I think frequency, intensity and timing are all fairly, or time being duration, are all fairly uniform when it comes to dosage of exercise in critical care. But when we're thinking about the type of mobilisation that we're completing, and as Bhakti mentioned this morning, the type of mobilisation we do in ICU is quite different to, I suppose, standard exercise prescription. When we talk about aerobic or resistive exercise, we're probably bringing it back down to how are we actually getting these patients moving. Are we doing goal-directed mobilisation? Are we looking at cycle ergometry, even neuromuscular stimulation? I think a couple of other key components which are really important when we're reviewing the evidence is around the timing, and as Bhakti's obviously mentioned, what is early, how do we stipulate early versus late, and the comparator. We know now that early mobilisation forms part of all clinical trial guidelines, so not providing mobilisation is really limited in our standard care. So what are we actually comparing? A lot of the time it's not apples to apples. So breaking down each component, looking at the frequency, and this is probably the one trial that really focused just on the frequency of mobilisation, which is Winkelmann's trial in 2018 that did once a day compared to twice a day of mobilisation. And they did show some benefit to that increased frequency of mobilisation, but none of it was significant. We did a retrospective note audit back in 2021 now with our patients, and we actually assessed the amount of mobilisation they did in ICU and correlated that with outcomes 6 months down the track. And you can see that once we achieved at least one exercise session every 3 to 4 days in the ICU, we ended up with a benefit in the health state 6 months down the track. However, we didn't find this to be an independent predictor when we correlated for other confounding factors such as age, illness, severity, length of stay. So then you look at WU's systematic review that's just been published, including 7 trials looking at mechanical ventilation duration, and they did show that more higher or moderate dose or frequency, and with that they stipulated 1 to 2 sessions a day for at least 3 to 7 days a week, and that did lead to a decrease in mechanical ventilation duration. However, when we think about frequency and implementing frequency in clinical practice, I think it's really tricky for us to get multiple sessions a day with our patients. They're obviously taken to scans, they're busy. It's really hard as a physiotherapist trying to implement that at the bedside. So then we think about intensity and measuring intensity for exercise prescription in a standard population, we talk about MET, so the metabolic equivalent of what patients are achieving. But obviously in ICU, we don't have collaborations to actually measure the METs every day. So we talk about intensity level and obviously using tools like the IMS to measure the amount of exercise that patients have achieved or the level. And we did this with our retrospective node audit as well. And we found that an IMS level of 5 was the cutoff point to actually an improved health state 6 months down the track. And we did find that this was an independent predictor when we accounted for all of our confounders. And this was correlated with Fust and colleagues' cohort study, observational study, where they looked at different characteristics of patients in the ICU and looked at the mobilisation level they achieved. And as they got up and walked, which is that IMS level of 7, then that was a 24-fold increase of them being discharged home. And then you've got the cohort study by Roost, Toronto and colleagues that was published last year that showed that if you achieve an IMS level of 4, which is only standing and weight bearing, that led to decreased ICU acquired weakness. However, we talk about the team trial and everyone talks about that being a high intensity trial, and we showed that obviously did lead to some increased adverse events. So moving on to duration, I wasn't able to show you the results of systematic reviews for the previous 2 components as we're unable to separate a lot of those, we're unable to categorise a lot of the trials in those 2, but the rest of these outcomes I'll be able to show some systematic review analyses. And duration, what is longer? We talk about 20 minutes, 30 minutes, 40 minutes. Fust and colleagues Lorenz and colleagues talked about 40 minutes of exercise a day as being needed to get improved outcomes. And this was correlated by the systematic review by Gallardo and Gomez that described 40 minutes of light exercise or 25 minutes of moderate exercise being required to get improved benefits. But then they really went on to describe they needed 40 minutes of moderate exercise and 70 minutes of light exercise. So then it's not just duration, it's also the type and the intensity. But how much do our patients actually do? And there's a couple of observational trials from Melbourne that showed we get less than 20 minutes a day of exercise, and that's at 1 to 1.5 METs. So that's pretty much what you guys are exerting now, just sitting on the chairs at rest. When we did our systematic review, and we used 20 minutes as our cut-off time for the papers that did report it, and we only found an improvement in function with a higher amount of exercise, but no other outcomes. These were measured at hospital discharge as well, or the closest time point to that reported. As I mentioned this morning, the increased duration in our frequentist analysis for this did show increased outcomes, but the Bayesian analysis showed a higher probability. The light boxes, I've made them light because they have high heterogeneity in the results, so the certainty in these results are probably a little bit lower. And as I reported this morning as well, the increased mortality with some lower duration, but that's to do whether that is, as I said, unadjusted, so whether it's more the clinical presentation of the patient rather than the amount of exercise they did. When we move on to type, and the last 2 big systematic reviews of both cycle and neuromuscular stimulation haven't shown any benefit to those types of exercise compared to progressive goal-directed mobilisation, which now has quite a lot of evidence behind it. When we did our systematic review, it didn't really matter whether you did goal-directed mobilisation or some form of other. So we grouped our papers in that manner of separating out goal-directed. We got improvement with length of stay, function and strength and ICU acquired weakness, no matter what you actually did. But we found improvements in cognition if you'd focus more on that goal-directed mobilisation. And as Bhakti was talking this morning about whether it is more that physiological change that the patient occurs. But we got an improvement in health-related quality of life more with the other types of exercise that was being implemented, and no real effect on adverse events or mortality. Think about timing, as we've talked about this morning, what is early. There is more benefit shown currently around early mobilisation within that first 72 hours, and the systematic review by Mengi's group in 2021 that separated out the time till 7 days. They classed anything within 7 days. They showed that that systematic review had 12 studies in it, and their results were inconclusive. When we look at our results, we got a benefit in length of stay and function with early mobilisation. Again, high heterogeneity in these results. But we got a benefit in strength if the patients actually did some early mobilisation later in their stay, but a decrease in ICU or acquired weakness if they did it early. But we did find significant improvements in both cognition and health-related quality of life if mobilisation was commenced within that first 72 hours. But as I mentioned in my trial this morning, the probability of increased mortality that we've identified in the systematic review published this morning, I think needs some further investigation and whether or not we are actually causing harm or benefit for our patients. Thinking about the comparator, so we know that this does affect influence our effect sizes. So Wang's publication in 2022 that looked at the control group stratification and those that received minimal exercise. If you separated out the groups that got minimal exercise to no exercise, you got a bigger improvement in your outcomes with the intervention. And Mengi's systematic review in 2021 showed that if you had an early mobilisation commencing later in the stay in the comparator group, again, that increased your effect size. So we separated ours out into some doing some exercise or some doing none, or very minimal, just range of motion in the bed. And length of stay and function, again, didn't seem to have any effect on what the comparator did, but we did get a benefit in both strength and ICU-acquired weakness if that comparator group were doing very little. But we got an improvement in cognition, and a significant one if there was some exercise in the comparator group and no influence on the other outcomes there. So I guess the big thing is, can we actually analyse these variables separately? You know, we talk about the team trial being a high dose trial, so it was a high intensity that commenced early with longer durations. And I think the information coming out of this group around the mobilisation quantification score is something that I think we really need to use when we're moving into future trials to be able to quantify the amount of exercise that's actually being achieved for us to be able to really analyse the outcomes. So they talk about this quantification score utilising the IMS as the intensity level and teaming that with the duration that they've achieved. They say that 1 unit is 5 minutes for all active sessions, but 20 minutes for passive sessions. So if it's that passive ranging or moving someone to a bed in terms of IMS 1 and 2, you need 20 minutes to actually get 1 unit. And then they look at a unit score of 8 as being the cutoff for a high dose versus low dose. And this was clarified in a systematic review by Mazawi's that was in stroke patients, but it does have 1,300 patients in it. And they did show that they used a cutoff of 7.3, which found that that was the cutoff to then getting some better improvements down the track. So thinking about some future directions, I think that we really need to improve the clarity of how we're reporting early mobilisation in our trials. When do we start it? How long are we doing? What intensity are we achieving? Because as we said, it all affects the response that the patient will have. We really need to standardise outcome assessments. The physical function analysis has 24 outcome measures in our systematic review, so hence the really high heterogeneity in the results, which just means we just don't have certainty in these outcomes. One big thing I'd like to see is separating the survivors from non-survivors and what those outcomes do mean for those two groups. I think we've shown that there can be a signal for higher mortality if we're doing early mobilisation. So then what is then, they're going to have lower ventilation durations and possibly lower short length of stay compared to the survivors. So are the outcomes like and like? And if we're going to do trials in the future, I think we really need to think about some novel ways to be able to separate the groups to get a separation of mobilisation effect. And Julie Bernhardt has just published their avert dose protocol, really looking at novel ways of integrating different ways to provide early mobilisation. So some key messages, I think we can now say it is safe, and yes, there may be some adverse events, but I think with some really clear monitoring and systematic assessment of patients to identify who will benefit from early mobilisation, I think we really need to make sure we are doing something with our patients. But the dose response is really complex, and I think that we need to look at ways to probably analyse that in the future to then get us a better outcome or understanding of the outcomes down the track. Thank you.
I'd like to open the floor for questions, comments. Go ahead, yeah.
No, thank you for that. That was really, really great. So my feeling is that this field is actually craving or would benefit from something that we have seen this morning on assessing HTE in mobilization, right? And I say that because if you look at trials outside critical care, like stroke, for example, we have the AVERT trial that suggested that early mobilization after stroke was actually harmful in a 2,000 patients trial, almost 10 years ago. And I feel like there is a lot of rationale to imagine that some patients may actually be harmed and some patients may actually benefit. So I'm wondering if you have something on the pipeline for that and how you plan to deal with that.
Funny you should say that. And I didn't prompt this question, but yes, we do. We're actually trying to collaborate to get an international management committee together to do an individual patient data meta-analysis. So we're just working through the protocol of that now. But we've identified 18 trials that have at least 100 patients randomised in early mobilisation. So we're going to be contacting those authors to see if they can share data, and hopefully we can get that individual level patient data to be able to say, it's also about what did patients achieve. So a lot of this systematic reviews are summarising summary data. So we talk about, when were they mobilised, and someone might have got activity on day 1, but someone else in the intervention group didn't get it till day 5, and we're already showing that may be a bit of an issue. So I think trying to individually analyse the data to be able to tease out some of these characteristics is the next step.
Yeah, sounds terrific. Thank you so much. So our next speaker is Professor Matthieu Schmidt from Hôpital de Paris. Thank you so much for...
So good morning, everyone. So we will discuss together about mobilization during ECMO, so a specific part of our patients' population in your ICU. Here my disclosure, not specifically related to that talk. So we know for a couple of years now, and it seems to be obvious that there is a clear relationship between the muscle weakness and the outcome of the ECMO patient. And this study highlights that point, showing that if you measure the skeletal muscle index or skeletal muscle density, if you measure it on the CT scan, it was associated with a longer duration of VV ECMO, whereas preserved skeletal muscle density was associated with enhanced ICU survival. And those patients are probably the sickest one in your ICU. And those patients, especially we have seen that during COVID-19 pandemic, these patients have a very, very long ECMO duration. ECMO duration for in that large cohort, in multi-center cohort, ECMO duration was a median of 18 days. You see that they spend more than a month in median on mechanical ventilation, and the ICU length of stay is nearly 1.5 months. And this clearly has an impact on their quality of life and the way, on the shape when they are back home. And you see in this study focused on long-term outcome that only 38% of this very young population were back to their initial work at 1 year. And if you look at the quality of life of those patients, you see that the physical impact is very important in those patients. So clearly there is a rationale to do early mobilization in this patient. Obviously it's maybe more complex in this population compared to a classical ICU patient. However, there are a couple of studies, mainly cohorts. The level of evidence is not based on many ACTs in this population. We have this large cohort study performed by colleagues from New York showing that out of 100 consecutive patients receiving ECMO in the ICU, only 35% participated in active physical therapy. So it means that even if you have a large experience center, if you aim to mobilize all your patients, it won't be possible to do it for all of them. However, 35% of them participated in active physical therapy, 19 were bridged to transplant, bridge to lung transplant, and 16 at the bridge to recovery, meaning classical IRDS. As you see, a large proportion of them had a dual lumen cannula, so it's a single ECMO cannula that you put in the jugular, which may ease the mobilization, and a few percentage of them are the VA ECMO, meaning that you have an obvious femoral cannulation. Those population receive 7.2 physical therapy session on ECMO. When you go into details, you see that 51% were ambulated, 9% were still on vasopressor but still receive physical therapy, 23 patients were liberated from invasive mechanical ventilation, and the final outcome is not so bad with 14 out of 16 patients who were bridge to recovery discharge who survived. And what is interesting is to see that out of 23 survivors, 57% went directly home without going into rehabilitation. And they didn't report any physical therapy-related complication. So regarding the potential impact of doing physical therapy in this subpopulation, we have this retrospective cohort showing that, which is quite expected, showing that if the intensity of mobilization is higher, it was associated with a better prognosis for those patients. There are some barriers to provide early mobilization, and the main barriers or the main facilitators could be a patient who are planned bridge to transplant. So for those patients who are bring to lung transplant, it's a very good subpopulation associated with an easier way to provide early mobilization. Obviously, the experience of the center highly impact on early mobilization, and if the patient is still on vasopressor, it will be a barrier which is quite obvious. So once the population which was investigated, it's the population of acute on chronic respiratory failure, meaning those patients who are already listed for lung transplant who get an ECMO because they did an acute respiratory failure. And in this very specific subpopulation, it might be interesting to cannulate those patients instead of providing mechanical ventilation. And this study shows that if you manage this patient in this way, by maintaining a rehabilitation when the patient will maintaining the patient non-intubated but just with the ECMO device, it was associated with a better outcome after lung transplant. So the patient went to lung transplant in a better shape and then had a better prognosis at the end. Another study with smaller patients, 14 patients, published in Intensive Care Medicine with end-stage lung disease, showing that 64% of them were successfully mobilized independent of cannulation site. And what is interesting is to see that 78% of them who survived to transplant had a maintained quadriceps strength. So this example of patient that we are mobilizing on a daily manner. So patient first can sit on the edge of the bed or into the chair, then go outside. Those patients have a very prolonged ICU stay, so it's very important even for their mind, for the well-being, to go outside and to see the sun. And some of them are ready to stand up on trachea with the cannula, with ECMO still on. And what we are developing since a few years, it's to have more intense activity like cycling, walking. So this is something that we do. However, it may be complicated, it may be complex. So there are several tips or several ways to overcome the challenge of mobilization on ECMO. First of all, you need to have an adequate checklist. And before mobilization, to be sure that there is no any kinking of the lines, to secure your lines, because what you are afraid of is a decannulation, accidental decannulation, and you have to check the length of the line. So we use this kind of security with sketchers or dedicated sketchers like this. During mobilization, you need to have someone who is responsible for the lines and to always see the lines. And what is important is that you're going to ask your patient to do an effort, so you have the ability with the ECMO device to adjust the supports that you are providing, the respiratory support or the cardiac support or both. And in that way, we frequently increase the sweep gas flow to balance the respiratory drive, which is going to be increased by the effort. And if the patient is on VA, you can increase your ECMO blood flow to provide more support to your patient to undergo this exercise. Obviously, you have to keep everything ready for emergency, and you need to have enough people involved, at least 4 people, so it's staff consuming. You need lots of staffing to do it. Always an intensivist, 1 person dedicated to the line, 1 with a backup chair, and 1 to support the patient. Be careful and caution is needed when you do activities involving hip flexion in patients with femoral cannulation. So it's really true for patients on VA, for example, when you have obviously you have at least 1 or 2 cannula on the femoral side. Do not forget that those patients have frequently other additional devices like EABP, like impeller, because they are very complex. So regarding the security of mobilizing those patients, lots of work has been done since a decade with some homemade helmet to try to secure the ECMO device, the cannula, when the cannula is on jugular. So this is very clever way. And now the industry is also working on that with more industrial devices to help to mobilize the patient. So you see there you may have like a shirt securing the jugular cannula, and then they are developing some specific device to help the patient to stand up or to sit at the edge of the bed in total security while integrating the ECMO device. So active physical therapy or early mobilization seems to be safe and feasible for patients receiving ECMO. Obviously, it won't be possible to do it for all your patients, but if you have a multidisciplinary team approach, it may facilitate the implementation of a rehabilitation program for ECMO recipients. Those population, the subpopulation, which has been studied a lot, are mainly patients who are awaiting lung transplant or those bridge to recovery, and this subpopulation may benefit from active physical therapy with a direct impact on the outcome after lung transplant. However, the level of evidence is still low, especially on this subpopulation, so optimal patient population remain to be defined. Is there any favorable impact on major clinical outcome? Do we really need it? Do we really need it to demonstrate it? And is it cost effective because it will consume lots of staff to perform this early mobilization? Thank you very much.
Thank you very much. Any comments from the audience? Yep. This was a
when we think about ECMO and its relation to the ventilator, so when we think about ECMO and its relation to timing of decannulation versus liberation from the ventilator and the indication for the ECMO, there was a recent trial of proning on ECMO that didn't show a benefit. So can you imagine a world where ECMO liberates you to mobilize first and, liberate from the ventilator and then decannulate later? Or what is the stage approach for you?
Actually, it's a very appealing strategy, which has been done in several patients. It seems to have a rationale to do it. In clinical practice, it's much more complex, because it's a very complex interplay between the central drive, the patient, and the ECMO. So it's a 3-part couple, and so in clinical practice, it's not feasible for all patients. And recent cohort have shown that for those patients who fail to be extubated, who are extubated and then reintubated, they have a worse prognosis compared to those who were still intubated. So as soon as we would have understand how to play with the respiratory drive, how to fake the respiratory drive, and how to play with, it will make it easier to apply this approach.
Okay, terrific. We have more time to the end of the session for further discussion. So if anyone has any questions for any of the panelists, I'm happy to just raise your hand and happy to discuss.
Yes.
Yeah.
Yeah, so maybe I have a question for Bhakti, because I was wondering, reading your paper, so how do you explain the improved cognitive outcome? Is this, in your study, is this related to lower levels of sedation, less propofol, or is it the occupational therapy in itself? So what do you think? What are your thoughts?
Yeah, so there was no difference in sedation dosages across both groups. And I think it's really that early timing, that early orientation to what is going on, that probably weds the mind back to reality as opposed to going somewhere else. And I also think it speaks to, in the usual care group, there was a low level of delirium, but it shows that there's a limit to awakening and breathing and coordination of that, and that what early mobility adds is this long-term effect. So I think what we really tried to do is make sure that the usual care got best practices. It's just that without the coordination and the structure of a study, at best patients were getting mobilized, day 5. And so I think the cognition is the occupational therapy, the coordination to the interaction with the environment that made the mind stay kind of present as opposed to going into the fog. And I don't have any more scientific way to say that. And then I think your other question about why was functional independence not different in a year, and why was quality of life not different? I think that functional independence, defined as getting back to your activities of daily living. Over the course of the year, these patients have gone to rehab, they've done all that, so they get back to doing the simple tasks at a rate, but they were sooner to arrive to that point on discharge for the intervention group, but you can rehab up over a year to get to where you're supposed to be. And the quality of life in terms of the physical domain was better. It's more just that I think quality of life questions about mental health are usually related to depression, anxiety, and so the cognitive gains that they had weren't really explained by a difference in depression, which could potentially affect your cognition.
I have a question for the whole panel. So thinking about all that has been presented, so if you have to design a trial and think about all the possible endpoints that one would have, it feels to me, this is not my field of expertise for sure, but at all these, let's say, functional outcomes, they tend to fluctuate over time a lot. Of course, they are patient-centered, but I'm very, let's say, suspicious that one single component or one single quality of life endpoint will actually change the way we practice. So there is one way that is being more pragmatic, using days alive outside the hospital, which is very pragmatic and maybe a good proxy. But I don't know if there is anything else, because I feel like those endpoints do not fit everything we need to test on those patients. I don't know if you have any thoughts or comments or.
One thing I think we really need to integrate is health economic data into a lot of this stuff. And as Matthias was saying, it's really expensive to do this. You need the staff, you need the expertise, you need the equipment to be able to provide early mobilisation. And is that actually giving the quality benefit to the patients? And that's why I'm really keen to look at survivors versus non-survivors and the outcomes that they have. And, some people would say that they'd prefer to die than actually be bedbound for the rest of their lives, whereas other people might actually prefer to be bedbound and be alive. So, and a quality of life year for one person is very different to another. Sure. But I think if we integrate some health economics in terms of the amount of utilisation of healthcare that these patients are getting, I think that will give us a little bit more indication of the benefit to this.
Piggybacking on that idea, I was struck by the graphics that you showed in terms of depending on the outcome you choose, that kind of helps identify where you get benefit or not. Do any of you envision a future where we actually sort of interview the patient and their family about what their goals of care are, what their priorities are in terms of what is a good quality of life, and actually tailor the approach to early mobilization based on those goals. So if someone is a mathematician and loves to have their brain but doesn't care whether their legs work, maybe you target early mobilization and or early sitting up versus someone who is a marathoner and doesn't much care about how their brain works. And I'm obviously making generalizations. You go. I mean, any thoughts about that?
This was something Bhakti and I were just talking about before, and whether we can utilise AI algorithms to possibly predict a type of exercise that some patients might be more beneficial to. And I think individual patient data level is needed to generate that, but definitely looking at baseline characteristics. And I know Carol Hodgson, who's my PhD supervisor, has a great slide of, what two people exercising and saying, what's your favourite exercise? And the other one says Sudoku. I think we need to integrate what patients want into their activities, because I think you'll get better outcomes if they're doing something they want to do.
Yeah, I think it's a little challenging because sometimes patients don't tell you or tell their families what they want at end of life, and then to sort of say which priorities they're going to do. And if you're trying to achieve it in that early timing, they usually aren't part of the discussion. So it would be ideal to sort of get that, but I also get pause because there's a nice study by Amal Jabran looking at LTAC survivors, like long-term acute care survivors who are on mechanical ventilation for a prolonged time, and it's a survivor bias, but 70% of them would say I would do it again, and so it's hard to know, to say what you would want before it happens versus what you might say after you've been through it. But I do think that there needs to be sort of an individualized treatment effect analysis. But those studies that are grouped in that analysis have to have similar interventions and similar to really understand, because most of these individualized treatment effect analyses require pre-randomization outcomes, and anything happens after randomization is where we'll bias that analysis.
Makes a lot of sense. Thank you. And for Dr. Schmidt, actually, a question with regards to, going back to how resource intensive these are, particularly with, in terms of the amount of staff and training of the staff that's required, how do you see us addressing that in the future? What's your ideal ICU in terms of being able to actually mobilize folks on ECMO on a regular basis?
I think if you want to do it well, mobilization for this specific subpopulation, clearly it should be done in experienced center. So you need to have a center with high case volume and who has all the staffing, the experience, the safety rules, and so on. So I think ECMO should be done in several centers organized around the network. With mobile ECMO team now, it's quite easy to do because ECMO could be accessible to many patients thanks to this mobile ECMO team. And I think this is the only way to get more number per centers and also to get more experience and to work on in that field of research.
Yeah, makes sense. Thank you. Yeah. If there are no other questions or comments, sorry, go ahead.
Thank you for a nice set of presentation. Can I ask you, is there any comparative study what happens 3 days after ICU discharge, after the whole rehabilitation plan, and you mentioned the study that they reach some target within the last 48 hours, and what happens next when you discharge them to the medical ward? Because I think this really influences the outcome at 6 or 12 months.
Thank you. Yeah, a lot of the work I've reviewed is only the mobilisation that's been achieved in ICU, but I think there was definitely some early trials that did try and do exercise after ICU rather than in the ICU that didn't really show a lot of benefit. Probably one of the trials that went the whole way through was Linda Dennehy's trial back from 2015 odd that did continue exercise not just in ICU but on the ward and discharge from hospital as well, and that didn't show any benefit. But again, that was a late commencement of early mobilisation. They didn't start their intervention in ICU till about day 8 of admission, so that's where I think a lot of people are focusing on ICU and saying that once it happens in the ward, it's probably a bit too late. But there are some good reviews that have come out around mobilisation in an acute ward, showing that doing more is better and you do get better outcomes. So I think we do need to kind of combine it all now and say, well, do the early, continue it through. And this is where Julie Bernhardt's trial on overt dose is looking at, I suppose, the different components of dose and trying to separate that out to then be able to see where is the benefit. Is it the whole way through? Is it just ICU? Is it down the track as well?
One more question, and this is really for anyone on any of the panelists. I wanted to come back really quickly to this comment that was made earlier about catabolic versus anabolic states. And I'm not exactly sure how early mobilization is planned in the clinical setting currently, but is there any benefit, do you think, to planning mobilization efforts specifically with a feeding or a timed feeding before or after and sort of timed nutrition along with it? Perhaps that's already done, and I'm showing my ignorance, but I'd be curious about folks' thoughts, both on the clinical side as well as in terms of our trials.
I'm not an expert on this, but there is an expert in the audience on nutrition. Do you have anything, Emma?
Thanks. I'm an associate professor from Melbourne, specialising in nutrition research. There's not a lot of evidence to date, so there's a couple of small trials ongoing, but they've been quite hard to recruit to. So you're combining two complex interventions, so exercise plus nutrition. And so I definitely think there is merit, but nutrition's in a similar position to mobilisation in that the literature at the moment is, I guess, confusing somewhat. We've shown with early interventions that probably isn't the way forward with nutrition as well. Usual care, which might be a high standard of usual care, actually is sufficient early on in critical illness, it appears. And so it's unclear at the moment whether combining those two things in the early period of illness will actually overcome the mechanistic aspects of critical illness. It may be later on for both mobilisation and for nutrition, but I think those questions aren't answered, and we definitely do need a trial, but it's a bit hard to know what direction to go in.
Thank you very much. Oh, yes, Dr. Heunks.
I still have a little bit of the feeling that we need to go back to the physiology here, right? I mean, we have taken really hundreds of biopsies of the diaphragm of ICU patients, and it's more or less the same for peripheral muscle. I mean, some of these muscles are very, very much inflamed, or there's a pro-fibrotic response, deposition of collagen at a certain moment in time. I think the question here is, what is the impact of mobilization in the different stages of muscle weakness in these patients? And I can really imagine from a physiological perspective that in the very early stage, when we do find inflammation, when there is a damaging response, that maybe mobilization is not such a good idea. So, I mean, it was a little bit of discussion we started earlier, but I think we're really looking for maybe biomarkers or imaging techniques that allow us to look at the muscle a little bit more into depth, to identify the patients that might benefit or might not benefit at all or even be harmed.
That makes a lot of sense. So almost going back to the idea of personalization, but specifically with regards to the state that the patient is in at the time that you're considering mobilization in the context of so many other variables that are going on. I love it. Thank you, everyone, for a stimulating discussion. This has been